My name's Sherin Jarvis and I'm a physiotherapist, and I've been working in the area of women's pelvic health for many years. I work with and I am a director of the Women's Health and Research Institute of Australia, which we refer to as WIRIA, and we're based in the CBD of Sydney. And I'd like to thank you for watching this video on vaginismus. Just as a disclaimer, the information in this talk is general in nature, and if you have any specific medical issues, it is advisable that you talk to your doctor. I'd like to talk to you today about my experiences working with women with vaginismus and what women have shared with me over the years, and as well different approaches to management of vaginismus. Vaginismus does have a medical name, genitopelvic pain penetration disorder, but for the benefit of this talk, I'm going to continue to refer to it as vaginismus. Now, just as a definition for vaginismus, it is involuntary contraction of the voluntary muscles in the lower 1/3 of the vagina, specifically the external muscles and then the internal deeper pelvic floor muscles. And vaginismus is an aversion to any form of vaginal penetration as a result of painful attempts. Fear of pain or fear of other outcomes such as pregnancy or harm or damage is what triggers the vaginismus. And the first clue that you may have vaginismus is that you may have had difficulty with tampons in the past or have never been able to use them. So what happens is when you try and have sex and it hurts, your brain takes a snapshot of that pain and decides that that pain must be bad. So the pelvic floor muscles contract in reaction to that pain to protect you. But with future attempts, the pelvic floor muscles switch on even before you've started to do anything, and they switch on in anticipation of the pain to protect you before the event. And it's an absolute paradox because it's involuntary contraction of voluntary muscle. And when we talk about voluntary muscle, we're talking about things like your biceps, quadriceps, and hamstrings. Those are your voluntary muscles, and pelvic floor is voluntary muscle as well. So what I'd like to do is just show this picture, and with vaginismus and pelvic floor muscle reaction, what happens is it hurts when you try and have intercourse. So then your pelvic floor muscles contract in response to the pain to protect you. Then your pain increases because you now have pelvic floor muscle contraction pain, and other muscles may also be involved. That increased pain increases the pelvic floor muscle contraction. Then you have anticipatory contraction, and now we're on a bit of a self-feeding loop. And that's where vaginismus it comes into play with the pelvic floor muscles. So vaginismus can be primary, which means you've never been able to manage penetration, or it can be secondary, which means in the past you did manage penetration, but for whatever reason it is now no longer possible. It affects about 1 to 7% of women, and it is cross-cultural. And some women may have specific views regarding premarital sex or sexual activity. Some women may have had a strict or religious upbringing. Some women may believe that sex will cause pain or injury or bleeding, or that their vagina is too small, or there's something wrong with them or something wrong with him. And early signs that you may have had this as an issue is that you've never managed tampons, and maybe you had to have a pap smear under a general anaesthetic, or if you presented one time to have a vaginal ultrasound and they needed to do it via your abdomen rather than your vagina. Some women may have coexisting mental health issues such as anxiety and depression, fears and phobias, or social phobia, which is shyness. Some women may have control issues or panic attacks. Some women may have social issues with a lot of stress at work and home. And some women have a history of childhood sexual abuse or assault and adulthood sexual assault, or almost abused or assaulted. And some women don't have any of these issues, just have had bad luck with first attempts. So I'd like now to talk about some of the physical contributors to vaginismus, and I think if you do have vaginismus, you may want to ask yourself some of these questions and see whether these scenarios apply to you. So in addition to pain with attempts at intercourse, some women might have really significant period pain, so heavy bleeding for about 7 days, passing lots of clots, needing days off school or work or uni, extreme lethargy, vomiting, diarrhea. Some women may have bowel pain. When they open their bowels, they have pain. Some women have pain that feels like period pain, but it's not period time. And some women need to go on the pill early in their teens to control the pain and associated symptoms. So those symptoms I just mentioned then are suggestive of endometriosis, and if you think you have some of those symptoms, you may need to discuss those with your doctor. Some women may have had infections elsewhere, so for example tonsillitis, and taken frequent antibiotics. And the use of frequent antibiotics can result in recurrent candida, which can make the vulval skin sore and inflamed and make attempts at any penetration very painful. Some women have been on a medication for acne called Roaccutane, and Roaccutane actually vacuums all the lipids out of the tissues, including the tissues in the vulval area, and can make that area very dry and cause contact pain with penetration. Some other women may have had a lot of procedures done as a child or in their teens if they were unwell for another reason, so they may have been traumatised by those procedures, and that pain and trauma might have caused their primary vaginismus, or some women have had procedures as an adult that resulted in secondary vaginismus. Another physical contributor to take into consideration, you can have vulval dermatological conditions such as eczema or dermatitis or psoriasis or itch. So there may be a vulval dermatological issue that needs specialist assessment and treatment. Other physical contributors can include atrophic changes that happen around menopause or early menopause related to breast cancer treatment. Some women experience hypoestrogenisation, so hypo just means under estrogenisation, and estrogen makes the vulval tissues pink and moist and vascular and elastic and spongy. And if you have had polycystic ovaries with very irregular periods or episodes, long-term episodes without periods, you may experience under estrogenisation of those tissues, or long-term use of a low estrogen pill or a progesterone-only pill, or Implanon or Depo-Provera in some women can cause hypoestrogenisation of those tissues. Some women who have been anorexic or dancers or athletes with long-term episodes of no periods may also experience this under-estrogenisation. And this under-estrogenisation can just make the tissues a bit red, a bit sore, a bit dry, a bit stiff, less elastic. Then they have skin pain with attempts at intercourse, pelvic floor muscles react, and then that triggers the vaginismus. Other physical contributors, some women may have scar tissue from previous radiotherapy to the vagina, may have had surgery or episiotomy, which is a cut during a delivery of a baby. Some women may have a hymen issue, and rarely there's an anatomical issue in the vagina itself. But it is worthwhile considering that there can be some physical contributors to vaginismus. Now I'd like to go and discuss with you what women have told me about their situation. So some women feel embarrassed or humiliated or ashamed at failed attempts at intercourse. Some women fear rejection of loss of the relationship or anxious about attempts at intercourse if they're not in a relationship, or they avoid dating because of this fear. Often they don't discuss it with their friends because they think they're the only one. Some women had minimal sex education, not sure what to expect, so a little bit naive about what might happen. One woman I saw was 40 and was mortified that she was still a virgin. Women have also told me that they fear the pain, they anticipate the pain, so I tighten up. The prospect is daunting. Many women say to me it's absolutely a daunting prospect, and that makes them feel extremely anxious. Some women hate the thought of anything in the vagina, so a finger, a penis, a tampon, anything going in. And occasionally women say to me that the thought of it is disgusting. And some women believe that their opening is too small, or that they have no hole, or he's too big, or something's going to break or tear or rip, and they think they're going to hit a wall, or something is wrong with me. Many women think something is wrong with me. Women have also told me that their girlfriends have told them horror stories about their first attempts. Or maybe a guy has made what's perceived to be a negative comment about the look or the size or shape of the appearance of their labia or their entry. So now I'd like to go and discuss what women have tried. So some women have tried painful and often very distressing internal trigger point therapies. They've also tried external musculoskeletal therapies. Some women have tried ovary therapies, which I'm not sure really what that is. Some women have tried dilators on their own in the past or with a partner. Some women have tried psychotherapy or psychology or cognitive behaviour therapy or hypnotherapy or EMDR, which is eye movement desensitisation reprocessing. Some people have tried sex therapy, counselling with or without a partner, and some people have tried support groups. Women have also tried using local anaesthetic gel to numb the area, or oral muscle relaxants, anti-anxiety and antidepressant medications, tranquilizers and alcohol. Some women have had surgery to remove the hymen or to remove part of the entry area of the vagina, or they've had other surgery to remove scar tissue and widen the opening. However, when we look at all of the things that women have tried, if you just do these as a standalone intervention, often it's not enough because it is multifactorial and standalone therapies are not as likely to be as successful. So now I'd like to talk to you about my observations working with women over the years who have vaginismus. Many women have had a strict upbringing, and there are some cultural expectations for some women to be a virgin when they get married. Some women have had minimal discussion of sex at home or sex at school, and they have had the girlfriend horror stories. Some women feel guilty if they've already attempted pre-marriage, and that can result in vaginismus. And it can actually be more common across certain ethnic groups. So for example, Indian women or Asian women or Greek, Italian and Muslim women, or if there's been an arranged marriage. Some women have had bad luck, had a little bit of pain, and that's triggered off the vaginismus. And some women just are a little bit naive about sex, the mechanics of it, have little understanding of what happens and little connection with that part of their body. So in addition to the mental health issues that I discussed earlier, I think some women have also got a few anxiety traits, such as being a nail biter or hair twirler, or they may crack their knuckles a lot, or they may scratch their skin a lot. Some women have control issues, they like to be in control. Some women may be a bit perfectionistic, and this doesn't apply to everyone. Some women have shyness or, as I said, social anxiety. If there's a lot of stress in your home life or work life, how do you handle that, and are you vulnerable, and does that make it harder for you to manage intercourse? Pain tolerance does vary, and a good way of testing that is to do a hamstring stretch to pain. So if you stand next to your bed and put one foot up onto the bed and pull that foot to 90 degrees to your shin, then link your two hands together and slide your two linked hands down your thigh and down your shin. If your hamstrings are tight, you won't be able to reach your toes. And if you've got tight hamstrings like I have, when you do that stretch, it hurts. But it's not harmful, and that's a reference point for your brain to go, okay, a muscle that's tight, when we stretch it, it hurts, but it's not harmful, and you can use that when you try to work with your stretches with vaginismus as your reference point to give you that idea of what a muscle feels like when it stretches. So some of my other observations, just about partners, are they supportive or not? Some women say to me, he's too supportive, I wish he would push me more. Some partners are very, very supportive. Is the relationship under threat? I often ask women, why are you seeking help now? And how long have you been trying? So some women say, I got married 6 years ago, I tried early on for about a year, it didn't work, we gave up, but now I want to have a baby, so now I'm motivated to do something about it. Or is the relationship crumbling? Or is there a new relationship, or is it just time to address it? So I also ask women about their goal. So if they have a partner, is the goal to be able to manage intercourse? Or if there's no partner, would their goal be able to manage tampons or an ultrasound or a pap smear, or to prepare themselves in case they did have a partner, or just to increase their confidence? So now I'd like to share with you some things from the guy's perspective. And this is what I've either been told by the males themselves or by the women I see. Some of them are very afraid of hurting her, and I've heard them say the look on her face when we try. Some of them back off physically and emotionally, and they live like housemates with their partner. Some guys get situational impotence, so even though the woman's worked her way through dilators to stretch her pelvic floor, because penetration takes so long to achieve, they can get situational impotence because it takes so long, they lose their erection, she's ready, he's not, everything falls apart. And sometimes they think if she sees a doctor or a physio or somebody like that and tries to do something about this, if everything's okay, maybe she doesn't want me as her partner. Some more observations from the guy's perspective. Sometimes just not pressuring her at all, and they both avoid. Some guys think that doing dilator stretches are pleasurable, so go and do them. This is definitely not the case. Some are fed up and are about to leave the relationship. And sometimes there's a discrepancy between his goal and her goal. So she might be keen just to have a baby, and she doesn't care if she uses a turkey baster or does IUI with IVF. He might be thinking, well, I've supported you through this. My goal is penetrative intercourse. So now I'd like to move on to approaches to managing vaginismus. Some women do need to work with a psychologist, psychotherapist, sex therapist or counsellor first. And this might involve counselling, CBT, hypnosis, self-hypnosis or EMDR. Some women need to do psychological therapies concurrently with physical therapies, and some women have come to a physiotherapy appointment with me first, have never seen a psychologist, and in that session I've decided with them that I really think that they're not ready to manage physical therapies and that they really do need to see a psychologist first. And some women may not need to see a psychologist. They may have just had bad luck. Their mental health's okay, they don't have any anxiety or depression. They can cope with physical therapies with support and encouragement and guidance. Some women, however, have had many months or years of physical and psychological, external, internal therapies, pelvic work, dilators, and no improvement, and they've really burnt out. And in that case, it's really important not to revisit old treatments and to help them move to Plan B. Now, if I can talk to you about what I would do with a woman with vaginismus, my perspectives as a pelvic health physiotherapist, I think it's really important to take a good history, and that regards all the things we talked about previously about period pain, all your period history. Did you have regular periods? When did you first go on the pill? Have you been on the pill for a long time? Explain vaginismus, that it's pain, the brain and pain, the pelvic floor muscles react to the pain to protect you. You anticipate pain, that triggers more pelvic floor muscle contraction like that diagram we showed you earlier, and the contraction of the muscles increases the pain. And I'd like now just to get my pelvis and show you what we're talking about with the pelvic floor muscles. So this is at the base of your spine. This is the front of you, and if I turn it around, this is the back of you, that's your sacrum, and right down the bottom, that's your tailbone or your coccyx. So if we go back to the front of the pelvis again, and now this is you standing up, but if I tilt this pelvis back down like that, what we're looking at now is if you're lying up on my examination table and I'm looking at you from below, this is the view that I'm looking at when I've got you up on my examination table. So right at the very top, is the clitoris. Then we have the urethra. Then this is the inner labia and the vaginal opening. This area here is called the perineum, and this around here is the anal sphincter. What I'd like to show you is there's a muscle right around the opening of the vagina, a slim little V-shaped muscle that attaches into a little fibrous nodule there. This is a very external muscle. It's a slim muscle and it's V-shaped. If we peel that and the anus off our model and then we go in deeper to the pelvis, maybe about 3 or 4 centimetres beyond this entry area, this is what I'm talking about when I refer to the pelvic floor muscles, these great big muscles here that go all the way from your coccyx all the way through to the back of your pubic bones here. And this muscle's wider and it's much more U-shaped. So we've looked at these 2 layers of muscle, a skinnier V-shaped muscle outside and a deeper U-shaped muscle inside. So when these muscles react in response to pain or in anticipation of your pain, they change their shape from a V into a W. So the skinny little outside muscle just flips up into a W like that. And then the bottom of the deeper muscle just flips up into a bigger W, but also the side walls of that muscle contract. So this whole contracting in anticipation of pain or response to pain, where the muscles change their shape from a U into a W, that means that it reduces how much space you've got because the muscles obstruct the opening and also in a little bit. And it increases the pain because if a muscle contracts, you get pain in that muscle itself as well. Now, pelvic floor muscles that we were looking at just here, they're voluntary muscles. And voluntary muscle contracts and holds, relaxes and stretches, and all of that is completely normal physiology for voluntary muscle. And as I talked about the hamstring stretch before, when you stretch a muscle, it hurts but it doesn't harm. I think what's really important too with vaginismus is looking at the language that you use, and if you use words like, oh, it was agony and it was terrible pain and it was so painful, that language informs your reaction. So I encourage women to use words or phrases like discomfort, not pain. It's just a muscle, it's just a bit tight, it just needs to stretch. We want the brain to turn down the volume. We want your brain to only give that sensation if you're doing stretches to your pelvic floor muscles. We want your brain to only give the value to that muscle of like a tight muscle or a tight hamstring, rather than it being much more dramatic or much more, using words that are very emotive that create a bigger reaction. Because we really want to be comparing this and referencing this to a hamstring stretch all the time. Doing this hamstring stretch is great. It's your reference point so that you can say to your brain, yes, it hurts, but it's not harming me. I'm a bit sore, but I'm safe, and the brain doesn't react as much. And I think reassurance is always really important, because there's nothing wrong with you. Everything's normal. You're just a bit tight, and you probably need to do some homework. So with the examination, when I examine a woman, as I've said before, I do this hamstring test, and it's really to get them to have an idea of the sensation of muscle on stretch. It hurts. Then I have a look at this opening area of the vagina. So I want to have a look at the size of it, the shape of it. I'm also looking at the skin inside the inner labia and the skin right at the entry area of the vagina. So I want to see, is that skin pink and moist and vascular and elastic and spongy, or does it look thin and papery and dry and red, and are there little splits or fissures or tears like paper cuts in the skin? Because the condition of this entry skin is very, very important, because if with contact with intercourse this skin hurts, that triggers off the muscle reaction and can trigger off the vaginismus. So when I'm examining you as well, I will examine the external muscles and the internal muscles. And the examination would be done with one finger, one gloved finger, and I use oil as my lubricant to examine, because oil is a great lubricant because it doesn't have alcohol and preservatives in it, and it's not likely to sting. And what I want to do when I examine those muscles is feel what they feel like at rest. Do they feel relaxed or contracted? Then feel the deeper muscles as well. Can these muscles contract, hold, relax, or are they contracted so much that they're in maximum contraction and they can't give me anymore? Can these muscles tolerate very gentle stretches downwards to 6 o'clock, especially if they're in this W position, externally and internally? Gentle downward stretches to 6 o'clock may be uncomfortable to start with, but if I do 3 or 4 repeats of those stretches, that discomfort or pain, hopefully not using that word too often, should reduce, because if a muscle stretches out and you continue to do stretches, that discomfort starts to ease. So if it's difficult to examine you with a finger, we may try doing getting you to breathe out if you take a slow breath in and slowly breathe out, see if I can get my finger in on an exhale. Or if you are able to do a gentle contract relax, sometimes using that as a technique for examination is really handy, because we can get the muscles to do a squeeze because that's what they want to do, but then we say to them, okay, now let go. And when they let go, that's when they go back into that U shape, and then the examining finger would go in 1 centimetre or 2 at a time with a let go of each squeeze, hold, let go. It's really important for women to slow their breathing down when they're being examined. So not to take deep, deep breaths, but to slow their breathing down as much as they can. Not to clench their jaw, because if you clench your jaw, you'll clench your pelvic floor, and not to be clenching your hands. So often women will have their hands on their tummy and they'll be squeezing, and I can see the whites of their knuckles, so we'll just take those hands and put them one on top of each other so they're not gripping, because it's all part of a flight and fight response. Your brain's decided this is harmful because of the pain. Your pelvic floor reacts, it's on. Pelvic floor asks for other muscles to come and help it, and the other muscles are the jaw clenching and hand clenching muscles. So if you're aware of that, you can try and use those things to your advantage. So what we're interested in when we examine your pelvic floor muscles, do you have any pain and burning? And as I said, that should decrease when you do several squeeze, hold, let go and stretch exercises. And if you're always referencing it with the sensation of the hamstring stretch, so that you're normalising that sensation and having in your brain that it's just a tight muscle. Now, sometimes it's not possible for me to do an examination with my finger. And I've got here a tiny dilator that is probably the size of my little finger. And sometimes with a tiny dilator like this, because it's very smooth and cylindrical and covered in oil, sometimes I can get that in more easily than I can get my finger in because of its shape. But also some women don't like the thought of a finger going in. So if I can get something like that in, that will even give me some more information about what the status is and then what we can do to help you. So, if you can't be examined either with a finger or with a tiny dilator, it is possible that there may be a hymen issue, and that's worth considering. Now, physical therapies that we might use in managing vaginismus. Education about what it is. It's involuntary contraction of voluntary muscle. It's driven 100% by your brain. So the result of vaginismus is physical. The muscles switch on and create a barrier or a wall to penetration. But the driver 100% is your brain, and it's the fear of pain or harm or damage. Reassurance and confidence building is very, very important, and I often ask women to start a positives list. So if a woman has come to see me and I was able to examine her, and if I was able to get something like this in and teach her how to get something like that in, I say to her, well, you were here today, I could examine you, I could get a little dilator in, you could get a dilator in, and you've got some homework to do now. So that's 5 things that weren't well, they didn't have a positives list before, but if we put them on their positives list, that's 5 things they can do now that they couldn't do yesterday. And it's really important to try and turn it around and use language that's positive and also encourage yourself to push forward. Some techniques for penetration to increase pelvic floor muscle relaxation. So penetration is anything. So tampon, intercourse, vaginal probe with an ultrasound or a pap smear. Using the contract, relax and something going in stages can be handy or helpful if you can do contract, relax. As I said before as well, being very mindful not to clench your jaw or not to clench your hands and to slow your breathing down. Now, for some women who can manage some penetration but not very deep penetration, this is called an O-nut, and it is it's actually to customize the depth of penetration. So there's silicone rings that stack one on top of each other that go onto the base of the guy's penis, and they come apart, so you can use just one, or you can use 2, 3, or you can use all 4 of them. And the idea is that it limits the depth of penetration that he achieves by going into you, but it doesn't reduce his sensation or feeling. So this is something that if you can manage partial but not full penetration, this O-nut might be helpful for you. And if you just have a look online, you can find where you can get that. It's not helpful if you can't manage any penetration. So this is for women who can manage partial, say a third in or halfway in. Lubricants. Oils are the best lubricant, however you can't use oils if you need to use condoms. And when I'm talking about oils, probably out of the oils that are good, the best one is organic coconut oil, so just the one you buy in the supermarkets or at the health food shop, so just that you cook with or put on your hair or do your teeth with. A lot of uses now for organic coconut oil. But organic coconut oil is buttery in its texture, and it's antifungal, antibacterial, and it's a moisturiser. Light olive oil, almond oil, or rice bran oil. Now, if you like the effect of oil but not the mess, there are 2 oil-based lubricants that have been thickened. So the first one is Olive & Bee, and that's Australian, and it's organic olive oil and it's been thickened with beeswax, so it comes out like a gel. And the second one is called Yes, OB, and OB just stands for oil-based. And you can find both of those online. Oils can't be used with condoms, but water-based lubricants can. And out of the water-based lubricants, the standard ones that you just buy in the supermarket and the chemist, they're often loaded with alcohol and preservatives, and they can sting sensitive skin. And if you have skin issues, we don't want to make your skin more sore. So you can get Astroglide Natural and Astroglide Ultra Gentle, and both of those are made from aloe vera, and they come in more like a gel consistency. Silk is made from kiwi fruit vine gel, and it is a little bit runny, but some women like it. Then there's another one made by Yes, WB, which is just water-based. So usually if you're looking for a water-based lubricant, we say try and find ones that are plant-derived. Then I also want to talk about vulval skincare. A lot of women think that they have to wash this area with soap. The best thing to wash this area with is just water, but at period time, if you want to clean the area better, then you can just use Sorbolene moisturiser. So you know that you buy in a pump pack from supermarkets, 3 or 4 squirts, and you can use it in the shower as a soap substitute. It'll clean the tissues, but it won't strip all the lipids off the tissues, and that's what we're trying to do. Make sure we don't make your skin down there squeaky dry and squeaky clean, because that makes it sting and hurt when you try intercourse. Now, I've shown you the small dilator, and what I want to show you now, I'm talking about dilators. They're sometimes called trainers, or sometimes they're called accommodators. There's no good word to use to describe them. I'm going to continue to use the word dilator, but acknowledge that I don't think it's a good word. Out of all the dilators that there are, I think these two are probably the best. The top picture is Hope and Her, and if you Google that, you can get that online. And the bottom picture is Femax. So the top ones are American, and the Femax are from the UK. This top one here has a pale mint green handle that clips onto different size dilators, and there are 6 graduated size dilators. These ones here, the Femax, I'll show you those. These are the ones I tend to use, and they come in a set of 4 dilators. This is the little one, number 1, and this is number 2. The dilators are actually hollow and they're threaded, so they screw into the base of each other. But because they're hollow, we can actually fill them up with hot water, so that when you go to use these, you're putting something warm into the vagina, and muscles stretch better in the presence of warm conditions. So they screw together like so, about 4 times. And so this one's the number 1. And if you were doing stretches with the number 1, this number 2 is the handle. And then when you've progressed on from stretching with number 1, the number 2 is the one you're stretching with, and the number 1 becomes the handle. There's 2 more dilators in the pack, and they screw into each other. I usually say to women not to look at the big dilator, because it is a bit scary when you look at it, and if that frightens you and puts you off a bit, it's best to just focus on the smaller ones and use the dilators that you know you can manage, so that you can then gradually progress through. Now, the dilators are aiming to do a graduated stretch and relax of these pelvic floor muscles, the external and the internal ones, to create more space. They're aiming as well to downtrain your anticipatory protective response, but also teach you to insert the dilator into the vagina yourself. You're in control of the situation, and to improve your confidence. So there's different types of stretches you can do, and they all have a different aim. So the first type of stretching is static, where you just put a dilator in and you just leave it there. You can start off by doing that just to get yourself familiar with putting something into the vagina. This is just aiming to make some space in the vagina, but if you're very tight, sometimes just putting a dilator in, a little dilator, and leaving it there, it can be a little bit uncomfortable. So I think it's good, if you can, to move on to what I call dynamic stretches. So with a dynamic stretch, what happens is, I call these active pull downs. You would have your tiny dilator in the vagina, and when you do a squeeze and a let go, you're actively pulling that dilator down in the vagina, downwards towards 6 o'clock, where that muscle is flipped up, and you're pulling it down to try and get that muscle to stretch out. So that's actively trying to lengthen the muscle and actively pulling down through the muscle. The third sort of stretch is called, I call them in-outs, where you put a slightly bigger dilator in for 5 seconds, take it out for 5 seconds, but do that 5 times, because if you only ever put it in once and it hurts, then your brain only ever has the memory of that being uncomfortable, And if you put it in the second time, it'll be less uncomfortable. Third time, it's getting easier. And then hopefully by the time you put it in the fourth and the fifth times, it's much, much easier. And so what you're trying to do is create new memories in your brain that you can get something in, it's not going to hurt, it's going to be comfortable, that you can do it, and you can progress through your dilators. Now, you do need privacy to do your dilators. I always recommend using oil to do the dilators, and you can do them on your bed or you can do them in the bath but no water. Now I just want to show you, this is roughly the position that we want you to use to do your stretches. So see, if this is you on the bed, you've got 4 or 5 pillows behind your head so that you're not sitting bolt upright and you're not lying flat. If you lie flat on the bed, you can't reach the dilators, and if you sit upright at 90 degrees, you can't get the dilator in. So sitting at this halfway between sitting and lying is an optimal position. Key thing is head supported, because if you're leaning your head forward to look at what you're doing, then your abdominal muscles are on, and if your abdominal muscles are on, your pelvic floor muscles are on, and we're trying to relax everything so you can stretch it. So this is roughly the position or the layout of the bath. The bath goes roughly at that angle, and you'd probably roll up a towel, pop it under your head so that you're not leaning forward. And then I would, if you were doing it in the bath but no water, I'd probably put an old towel underneath you in the bath as well, and just be careful to clean up all the oil at the end, because you want to make sure that the bath is not slippery for the next person who's going to actually use it. So what I've found with dilators and trainers is, without good education, supervision, encouragement and support, to have the confidence to push through and to progress, if you're doing this on your own at home, often women discontinue because of lack of success with dilators and frustration. Or I have some women come to me in the clinic and they come in with their box of dilators and they've never even opened the packet. So I think it's important to have that encouragement and support to do your stretches, because it can actually help you feel confident to push through and know that the person who's guiding you has got the experience and confidence to take you somewhere where we know it's safe. Now, I talked before about Plan B. So if you've done a lot of work with dilators and you haven't made enough progress with your stretches, Plan B can sometimes include using botulinum toxin type A. We refer to it as Bonta, but the two brands that most people are familiar with, first one is Botox and the second brand is Dysport. But you would use this if progress was slow, very frustrating, and you still had a lot of discomfort with all your stretches. So Bonta is it's purified botulinum toxin type A. It's a neurotoxin, and it blocks the release of the neurotransmitter acetylcholine. It's a muscle weakening agent, and it stops the muscle from contracting. And over time, the muscle loses bulk, and it's similar to having your arm in a plaster. If you break your arm on Saturday night and they put you in a back slab and wrap it up in a bandage and say, come to the fracture clinic on Tuesday. When they unwrap your arm on Tuesday, none of the muscles have wasted in bulk at all. But then they put you in a plaster cast and you wear that for 4 to 6 weeks. When they take that plaster cast off, because your muscles haven't been working all that time while you've had the plaster cast on, when they take it off, those muscles are really skinny. So that's what happens with Botox. It doesn't make your muscles skinny, but it stops them being so bulky and contracted, and it gives us this window of opportunity, acting as a circuit breaker to help you with your dilator stretches. Now, it takes about 10 days to start kicking in, and because the effect is cumulative, so a little bit happens, a little bit more, a little bit more, a little bit more, over time, that build-up of the cumulative effect, you start to see it working really well by week 3 to 4, and that's when you'd start doing dilator stretches. It lasts up to 6 months. And what we hope is to only do the injections once, and if you follow up and do maintenance stretches well beyond this, you can really preserve the effect in the muscle. But here's the rub, it's not a magic wand. It's a window of opportunity to rehab those pelvic floor muscles, do your stretches in the absence of that pelvic floor muscle contraction in reaction to what it perceives as pain, or the anticipatory pain or anticipatory contraction. And it creates new muscle memories. So women can then put dilators in, they can do their stretches and go, oh my goodness, I can get things in, it doesn't hurt anymore. This is so easy, it's made the process easier. However, you do need to do diligent dilator work to get these muscles to have a prolonged effect. And even if the Botox wears off by maintenance stretching, you can keep it working. So it's highly effective in appropriate cases. It's not first-line management. It's done in hospital under a light general anaesthetic. Hopefully we only need to do it once. And as I said, you do need to do maintenance stretching. So thank you for watching this Wiria video clip.